This podcast has been produced on the traditional lands of the Gadigal and Bidjigal peoples. From 2RPH and the Wicking Trust, this is Passing Thoughts. I'm Rob Kaldor. This is the podcast where we investigate death, dying, and everything in between. Today on Passing Thoughts, Jane Mundy dives deep into the essentials of advanced care planning. Later, Jane talks to Christine Matthews, who carried out her aunt's advanced care plan and now advocates for others to put theirs in place. Stick around for this. In our Before We Go segment, I investigate the idea of a living funeral, but in this case it goes horribly wrong. But first, Jane chats with Catherine Joyce from Advanced Care Planning Australia.
So imagine you've become seriously unwell. Maybe you've had an accident and gone into a coma, or you're in an advanced stage of dementia and you're unable to communicate or make decisions about your own health care. Who would you want to make these difficult decisions for you if you can no longer speak for yourself? Healthcare professionals who may hardly know you, or someone close to you who knows you well and understands what matters most to you and what you want your future life and healthcare to look like. Dr. Catherine Joyce, National Manager of Advanced Care Planning Australia. Catherine, can I start by asking you, what is advanced care planning?
Advanced care planning is planning for your future healthcare in case there comes a time when you're not able to speak for yourself. So advanced care planning involves thinking about your values, your beliefs, your preferences, talking about those with the important people in your life, and sharing those wishes and preferences so that they can guide your care if that time ever comes.
How does advanced care directive fit into the process of advanced care planning? Because it's quite a specific thing, isn't it?
An advanced care directive is one of the formal documents that you can complete as part of the overall advanced care planning process. So advanced care planning is a voluntary process. It's not required for anybody. People can choose to do it and they can choose how they want to do it. One of the choices they can make is to complete formal documents, and an advanced care directive is one of those.
So it can be a fairly informal process, are you saying, or quite a formal one involving a specific form that's available that people can use, or just somebody writing down their wishes on a piece of paper?
It could be as informal or as formal as people choose it to be. So it might be simply a conversation with that person who's going to be in the position of making decisions for you if you're not able to decide for yourself about your health care. There are some formal requirements around some of those formal documents in terms of things like signing and witnessing requirements. However, it can just be, and certainly we would encourage people to start the process by having that conversation, doing some reflection themselves and having that conversation.
So essentially it's for a situation where a person is no longer able to make decisions for themselves.
That can happen either on a temporary basis or a permanent basis. So sometimes if someone has had a serious injury, for example, or a serious acute illness, there might be a period where they're unable to make those decisions for themselves, but then they may fully recover. In other circumstances, a person may not regain that ability to make decisions for themselves. And if we think about some illnesses and conditions, for example, something like dementia, there may be a long period of time where decisions about someone else's healthcare are needed.
Can you give us some examples of the kind of situations where an advanced care directive can be useful?
An advanced care directive serves two overall purposes. One part of that is general statements about values, wishes and preferences, what's important to the person around their future health care. So that might be things like where they would prefer to be cared for, what kind of outcomes they would or wouldn't want in their future. The second part of it is making specific instructions about particular interventions that they would or wouldn't want. And a typical one there is CPR, cardiopulmonary resuscitation. So do people want to receive that resuscitation or not?
Why is advanced care planning important? I imagine one thing is that it takes away that burden of decision making if a crisis situation happens. It's all written down, people know in advance.
Being in that position of having to make literally life and death decisions for another person is incredibly stressful. It's often happening in a crisis. And so anything that we can do to plan in advance for that, to support that person making that decision, is going to be helpful. And if we have something that's been written down, then that can really support communication and can support that person to advocate for the person with the healthcare team. This is what they have told us they want.
One of the difficulties is planning for an unknown or an uncertain future. We don't know what's going to happen to us in the end, do we? So how specific do we need to be?
Of course, we can never plan for every eventuality, and that's why those general statements are also very important, as well as the more specific instructions. Because those general statements, and particularly thinking about the outcomes, what are the outcomes that this person does or doesn't want? That's the kind of information that can help a decision maker understand. They can put that information in the context of the particular decision that needs to be made, and they can ask questions of the healthcare team about what will be the outcomes for this person if we do or don't do this intervention.
An advance care directive is a legal document, but it's not quite like a will. So must this be followed by health professionals in the same way as any legal document must be?
So it is quite complicated, Jane, because there are two parts to an advance care directive. One part is those specific instructions about specific medical interventions, and that's the part which is legally binding. The more general statements are not legally binding. So there's different parts to the document and they actually have different status.
Are there circumstances when an advance care directive doesn't have to be followed?
With those specific instructions, the general rule is that those legally binding instructions do have to be followed, but there are some exceptions to that. For example, some of the things that might apply, if the instructions are not consistent with good medical practice. So if somebody gives an instruction that they want some unproven treatment, doctors can't be compelled to provide that. Another instance is if the instructions are not specifically clear, if they're ambiguous or uncertain, then again, they might not be followed. And the final really important one is that doctors don't have to provide what's called futile or non-beneficial treatment. So if they make a clinical judgment about this person in these circumstances that they don't have capacity to benefit from a treatment, they're not obliged to provide it.
So that's the definition of a futile treatment that the patient would not benefit from.
So even if somebody has an instruction saying, yes, I do want to have CPR, if the clinical judgment is that this person does not have capacity to benefit from it and the burdens of the treatment outweigh the benefits to the person, the doctor is not obliged to provide it.
And would there be a lot of discussion at that point between all the parties involved?
Of course, Jane, those really important medical decisions would always be made with as much thought as the situation allows and as much consultation as the situation allows. And I guess from our point of view, what we would want is that people's instructions, what their wishes and preferences are, have been made as clear as possible to help inform those decisions. And good medical practice that there is consultation, all of those things are considered and explained as part of that shared decision-making process.
Not everyone is open to talking about advanced care planning. It can be a difficult topic to raise.
People might be surprised at how open others are to talking about this. So we conducted a survey in 2025, over 3,000 adults across the country. And what we found was that once people understood what advanced care planning is, 73% of them, that's 3 out of 4, are really happy to talk about it. So I think you might be surprised that people are more open than you think. And I guess as well, one of the things to think about is it doesn't have to be all at once. And it doesn't even have to be about end of life or dying. It can just be a conversation about if something happened to you tomorrow, what would you want? Let's start there.
What questions might you ask if you were beginning a conversation like this?
One of the really helpful ways for people to frame this conversation is to bring it back to that idea that this is what's going to help the person who needs to make a decision in those circumstances. So I'm asking you about this because I want your help to do the right thing by you if the circumstances ever arises.
And I imagine it must come as quite a relief for everybody in a way that the person who's reaching the end of their life is confident that somebody knows what they want, and equally the person that's trying to guide them through that, the substitute decision maker, knows what the person wants. So it's a win-win.
The two key benefits that came through in our national survey, one was that peace of mind for the person themselves, that things are in place and that they've communicated what's important to them. And the other is that easing the burden for the person who's in the decision-making role.
So the earlier these conversations can start, the better.
Absolutely. It is an ongoing process and an ongoing conversation over a period of time. It's not just filling out a form and it's done.
That was Jane Mundy with Catherine Joyce from Advanced Care Planning Australia. We continue our deep dive into advanced care directives. Jane is talking to Christina Matthews.
Christina Matthews was a nurse for 33 years, much of that caring for people with life-limiting illnesses. She has also acted as substitute decision maker for several members of her own family. So, Christina, you've cared for people at the end of their lives, both professionally and personally. Let's start by talking about Aunt Mari. She was very special to you, wasn't she? Can you tell me about her?
I love talking about Mari. She was Dad's sister, and they were both very close. They were about 18 months apart. So a lot of my childhood was spent with her. She was an educator. She was a teacher. She lived for 20 years of that in remote Arnhem Land in the Northern Territory. So we would see her in school holidays, and she made our lives remarkably fun. She was involved in the care for her younger sister, who had a multitude of problems and was intellectually disabled. So she knew what caring was about, and she knew what that involved. So when it came her time to be cared for, she was ahead of the game, and she knew what was involved for the carers to help her.
And sadly, Mari was diagnosed with cancer at the age of 85.
That's right, Jane. Yes, at 85 she was diagnosed with esophageal cancer that was inoperable. And when you say that out loud, there's an expectation that treatment would be very considerate of that. However, for her to receive palliative care and her wishes to be maintained, me as her substitute decision maker, that was a hard slog. That was hard work. The system had other ideas for her.
Because you were very close, obviously, throughout your life. You'd been talking to her for years about the kind of care she wanted at the end of her life.
Absolutely. And I think a peak time for that thought process was when her eldest sister was dying. We were told that she was receiving palliative care and her death was soon. And then when we got to the hospital, she was in intensive care and hooked up to monitors and assisted breathing. I had to then very quickly make decisions on her behalf for a peaceful death, and that was very traumatic. And she watched that, and that reinforced her to make the decisions she did and put her directives in writing.
So how did those early conversations with Mari go? Did she say, I'm just starting to think about the end of my life? How did that happen?
Because we were so close and she knew I was a nurse and I had seen the processes that people go through, she had this joke, and this was 2 years before she was diagnosed. Oh, we better have lunch because I'm going to die soon. We better enjoy the day because I'm going to die soon. So, and because we were simultaneously planning for my other auntie, Carmel, for her younger sister, when we were doing things for Carmel, we were thinking about things for Mari as
Yeah.
well, even well before the diagnosis.
And what was it that Mari wanted for herself?
She was very specific about dying at home. She wanted to die in her own home. One of her first directives, because I've kept her directives, because I find even though she passed away years ago, they're still a comfort for me. Her first directive was to ensure that her caregivers were given both autonomy and comfort in her dying. If we couldn't achieve what she wanted, that was okay, but we gave it a good hard go.
She was thinking of you too,
Yeah,
wasn't she?
She was the whole time. So she wanted to die at home. In Australia, about 14% of Australians actually get to achieve that goal.
Yeah.
And I'm sure the percentages of people that want to is way beyond that. That took a lot of planning, and it took a lot of understanding of the people that were, I call them the gatekeepers. So her GP was part of that process, and he was downright amazing because he knew her as a human being. He knew her before she had her diagnosis. So he knew her values. He knew how she managed her life. So for him, that was a no-brainer.
That might not always be the case. There must be a lot of people who have not had a GP for a long time like that, who haven't ever got to know the GP, or more to the point, the GP hasn't got to know them. And so it's more complicated than that sometimes, isn't it?
It's absolutely more complicated than that for most people. Personally, my own GP refuses to talk about that with me. I'm not the right age.
It's the whole point, isn't it, to do it in plenty of time?
Absolutely.
Besides wanting to die at home, what were Mari's other wishes?
She didn't want any care that was futile. She didn't want tubes, probing, procedures. She wanted to stay away from anything like that. I think she was quite, I wouldn't use the word traumatised, but how she experienced her sister's death was traumatic for her and very unnecessary. So comfort was a big thing for her. She wanted to be comfortable. She didn't want to be poked and prodded. But she was also an educator, so she was quite curious about all the research and the data around death and dying. So she was happy to go along with what was new in the death world and what was happening. And for myself, as her carer, I fast-tracked my learning as well. So I went to numerous webinars and listened to numerous podcasts about how people took their own initiatives and their own autonomy out of the healthcare process.
And then she wrote down her wishes. That was important to her and you, to actually write it down, as opposed to just talking about it.
I think it's important to have documentation, and we tend to focus a lot on legal process, but I think just in human process, when things are written down, your brain is wired to process them and understand them, and not everybody in the family and in her social circle were happy that she was dying, but were content that it was the right choice that she made. They wanted her to fight. They wanted her to receive treatment. They wanted her to be in a hospital. They wanted her to maybe try something to prolong her existence. For me, as her substitute decision maker, it was just a blessing to have those papers because I could leave them out for people to read. And when I was having very difficult conversations with some family and friends, I could say, read this. This is what Mari wants, and it's written down. So I've kept those directives. So even after her death, they're a special part of my grieving to have those.
Was there a form involved that you filled in, or did you just do it fairly informally, or how did that process of writing it down happen?
So there was a form. So we rang Advanced Care Planning Australia, and I've rung that number quite a few times. You don't do your directives and then bingo, it's all good and done. It's a process, and you're meeting people all the time, and you're dealing with new treatments, new decision making throughout that entire process. So I had a lot of phone calls with Advanced Care Planning Australia in regard to how should I manage this? What form do I need for that? Could you send us some more information? So they were great. Arnie Murray used to call it her homework. So she wrote her directives in pencil first because she wanted to get it right. And then she wrote her final directives in pen.
And I guess they're not set in concrete either, are they? You can change, if, let's say a new treatment became available suddenly. You can change your directive.
Nothing is in concrete, and humans aren't concrete. So during the course of her illness, there were times where she did have treatment. It improved her quality of life, her day-to-day living, and that was fine. And she chose to do that. But I think if people out there are expecting healthcare workers and professionals to be reading directives step by step, I think that's a little bit naive.
Yes.
As a society, we have a problem with death and dying. That society involves doctors, nurses, physios. Yeah. We're all humans and we're all part of that society.
Yes. Big question. Were Mari's wishes carried out exactly as she had directed?
Yes, they were. They absolutely were. And it was amazing.
She was so incredibly fortunate to have you as her advocate. Did you make them happen, or the fact that they were written down would have ensured they had anyway?
Her family and friends made them happen. I think it could have very easily not happened. There were times when her pain was getting difficult. Her symptoms were getting difficult for us to control. So there was a process of then sitting back and thinking, okay, if we get treatment for this, what does that mean? What does that mean for her as a human being? And it's not a tick box set and go. It's a constant process. But I think there's a wide gap between what everyone thinks happens in a hospital to what happens in a hospital or any sort of institution.
And you do wonder what happens for people who don't have others to advocate for them, don't you? They may have wishes, they haven't been able to express them, maybe nobody's been interested in hearing, and then at the end of their lives, they're really at the mercy of others to make those decisions for them. Mari was incredibly fortunate to have you.
I think we were fortunate to have each other, and also I've experienced at the bedside what happens to people who don't have anyone, or their people just aren't aware of what's going on.
People who do have somebody, but even then, you've got to make sure that that happens, and it might not always be that easy.
I think people might want something, but it's not as simple as that. Even with the process, there's difficulties all the time. So even to get Arnie Murray palliative care, she was refused palliative care when she first presented to an oncologist. She was 85 years old. She had inoperable esophageal cancer, and yet he refused to refer her to palliative care.
And so what happened?
I demanded that we have a referral. And I had a bet with her. I said, you're going to go into this appointment and he's going to refuse to give you palliative care. And she said, no, that's not going to happen. And I said, I'll bet you a latte it does. So I scored myself a latte that day.
Very frustrating and disappointing, isn't it? That, people can be so clear about what they want and yet it's still a job to get it done.
I think, Jane, life's a job. If we go with the pathway of thinking assuming that everything's going to just happen. And look, hospitals are great. I have so much respect for the medical profession and for the nursing profession that I was part of for so long. But I think I'm determined to make things easier for everyone, and not just my family, but everyone's family.
Do you feel that you're a bit of a pioneer in this? That you know, people are going to take advanced care directives more seriously?
I don't know that I'd call myself a pioneer. I think there are so many great human beings out there that are doing amazing work in this area. I'm just happy to go along for the ride and do what I can to make it happen.
Have you made an advanced care directive for yourself?
Damn straight I have. And I've got myself a new GP. So I'm a healthy, fit 56-year-old woman, but life happens and it's good to have these plans.
And that's the point, isn't it? None of us know what's around the corner, and this is about being prepared in every way we can.
And being prepared doesn't mean you're asking for it. It doesn't mean you're going to jinx something. It's just you're prepared for yourself, but you're also prepared for the nurses and doctors that are trying to help you. You're prepared for your loved ones that are watching this whole thing unfold. You're preparing for so many people that you might not even realise. And you're preparing for their grief. To grieve someone when you know that you've done the best you can for them is phenomenal.
And I can understand why keeping the advanced care directive yourself, because there it is, and you know that you achieved that for her, your beloved aunt.
That's absolutely right.
A big thank you to our guests for this episode, Christina Matthews and Catherine Joyce from Advanced Care Planning Australia, and of course the wonderful Jane Mundy who brought us the story. Before we go, in previous episodes we've touched on the idea of a living funeral, a living wake as it's often called. It's a gathering held while the person is still alive, so they can actually be there for the tributes. During a recent bout of insomnia, I revisited one of my favourite shows, Curb Your Enthusiasm. It's created by Larry David, who also created Seinfeld. For anyone who hasn't seen it, it's a cringe comedy about a fictionalised Larry who repeatedly derails his own life through petty grievances, social missteps, and a near heroic commitment to being technically right. In one episode, he attends the living funeral of fellow comedian and filmmaker Albert Brooks, and let's just say things don't go as planned. Here is Larry David with the opening eulogy.
It saddens me personally to be here today, mainly because my dear friend Albert Brooks is very much alive. It would have given Albert tremendous satisfaction to see all these people gathered here to pay their last respects to a man they will see again in less than an hour. Come on, man. I'm very sorry that Albert is faux dead, because I was going to leave him some faux money. And know this, Albert is the one who inspired me to become a stand-up comedian. And that, more than anything, makes me wish he was really dead. And now I'd like to bring up another friend of Albert's, who was also coerced into doing this, Mr. John Hamm.
But this is where things get pear-shaped. As Larry hands over the microphone to the next speaker, he goes to the bathroom but opens the wrong door. And to give you context, this was supposed to take place at the tail end of COVID.
He's a COVID hoarder. Albert Brooks is a COVID hoarder.
He's a COVID hoarder. Albert's a COVID hoarder. Are you kidding me? Look at this, John Hamm.
We're doing in the closet. What's going on here?
Look at all that toilet paper.
And Purell.
First responders could have used all of that stuff. Why are people...
So I suppose the message to take from this is, if you're having a living funeral, make sure you have no skeletons in your closet. Passing Thoughts is made with the support of the Wicking Trust and the team from 2RPH. And remember, we'd love to hear from you. So if you have any feedback, topic suggestions, or just want to share your own experience, please email us at passingthoughts@2rph.org.au.
This is a Radio 2RPH production.